treatment of intracranial tumors, airway protection, dexamethasone for increased intracranial pressure, mannitol for herniation, definitive therapy with excision, radiation therapy, chemotherapy, or combination. Patients in a coma or with impaired airway reflexes require endotracheal intubation. Brain herniation due to tumors is treated with mannitol 25 to 100 grams infused IV or corticosteroid, example dexamethasone 16 milligrams IV followed by a 4 milligrams orally or IV every 6 hours, and endotracheal intubation. Hyperventilation to a carbon dioxide partial pressure of 26 to 30 mm Hg can help decrease intracranial pressure temporarily in emergencies. Mass lesions should be surgically decomposed as soon as possible. Increased intracranial pressure due to tumors but without herniation can be treated with corticosteroids. Example, dexamethasone 4 mg orally every 6 to 12 hours or prednisone 30 to 40 mg orally twice a day. Treatment of the brain tumor depends on pathology and location. For acoustic neuroma, see acoustic neuroma. Example, surgical excision should be used for diagnosis, excisional biopsy, and symptom relief. It may cure benign tumors. For tumors infiltrating the brain parenchyma, treatment is multimodal. Radiation therapy is required and chemotherapy appears to benefit some patients. Treatment of metastatic tumors include radiation therapy and sometimes stereotactic radiosurgery. For patients with single metastasis, surgical excisions for the tumor before radiation therapy improves outcome. Now coming to end-of-life issues. If patients have an incurable tumor, end-of-life issues should be discussed and palliative care consultation should be considered. Cranial radiation therapy and neurotoxicity. Radiation therapy may be directed diffusely to the whole head for diffuse or multicentric tumors or locally for well-democrated tumors. Localized brain radiation therapy may be conformal, targeting the tumor with the aim of sparing normal brain tissue, or stereotactic, typically involving gamma knife or proton beam therapy. Gliomas are treated with conformal radiation therapy. A stereotactically directed gamma knife or a proton beam therapy is useful for metastasis. Current recommendations are to treat more than 4 metastatic lesions with a stereotactic or other focal radiation innovation and to treat less than 4 lesions with whole brain radiation therapy. Giving radiation in smaller fractioned daily doses tends to maximize efficacy while minimizing neurotoxicity and damage to normal CNS tissues. Degree of neurotoxicity depends on cumulative radiation dose, individual dose size, duration of therapy, volume of tissue irradiated, individual susceptibility. Because susceptibility variation, prediction of radiation neurotoxicity is imprecise. Symptoms can develop in the first few days or months of treatment, early delayed, or several months to years after treatment, late delayed. Rarely, radiation causes gliomas, meningiomas, or peripheral nerve sheath tumors years after therapy.